So, thank you very much. Now we move to Lakshmy Ramakrishnan. I hope I pronounced that nearly correctly, from the Observer Research Foundation in New Delhi.
Good evening, everyone. Thank you to the chair for inviting me to take part in these proceedings. So the presentation I've made is entitled From Crisis to Preparedness, Reimagining Health in India. So in this presentation, I'd just like to illustrate to you how COVID-19 was a transformative point in India where health, which is typically seen as a developmental issue or from an aid perspective, transformed into a security issue. So I just want to describe to you how COVID-19 was securitized by a political actor in India and how this contributes to the wider debate on whether securitization is indeed useful or not. And it also provides insights into gaps in India's health governance framework. So a broad roadmap to the presentation is I'll just describe how securitization unfolded in India by describing how a discourse analysis was done, looking at the speech acts made by the Prime Minister of India, and how this has given rise to unintended consequences, not in health, but in another sector. And that tells us that we need to reconsider whether or not securitization is beneficial, and how this has also led to more policy discussions on India's governance frameworks. So COVID-19, as we're all aware, is a unique health crisis. So it did not just have an impact on health, a short-term impact on health, but also cases of long COVID demonstrate to us that it has a longer lasting impact. It also caused loss of life and livelihood, and it also affected other areas, including threats to food and nutritional security, as well as economic impacts. So it's essentially a health crisis that has given rise to interconnected crises as well. Now, the other important aspect of COVID-19 was that it had a link to security. And the link between a disease or a health issue and security is something that is not new. So HIV/AIDS was already considered to be a threat to mankind, and it was even raised as an issue in the UN Security Council in the year 2000. So typically when securitization or the elevation of a health issue into security politics occurs, it is to ensure that there's political mobilization as well as financial mobilization to address that particular issue. So in the case of COVID-19, when the WHO called for preparedness and for countries to advance their emergency response mechanisms to flatten the curve, it meant that the responsibility to implement those measures lay with the leaders of national governments. And if you look at the speech acts that were made by leaders of national governments at that time, most of them framed COVID-19 as a security threat by invoking the narrative of war. And this is essentially a securitization process. So the process by which an issue is presented as an existential threat that necessitates emergency measures, and it justifies an issue moving from normal politics to exceptional politics or security politics. Essentially, we had to implement stringent public health measures during COVID-19. And this was quite unique because it was a transformation that occurred at a global level. So how did this happen in the Indian context? So in the Indian context, what I wanted to just highlight today is that it's unique because it essentially moved health, which has been viewed as a developmental agenda towards a security agenda. And that is very new for a country like India. And examining how COVID-19 was securitized uncovers, as I mentioned, whether or not securitization is useful or not, because it leads to unintended consequences which are not beneficial. And it also reveals governance challenges that India is currently facing, and it impacts how India will react to future health emergencies, which also has a global impact as well. And in this particular study, what I've done is I've carried out a discourse analysis to study how securitization unfolded in India, and then onto the policies aspect, carried out roundtable discussion with experts to propose policy improvements. So how did COVID-19 emerge as a threat in India? So the first case of COVID-19 was reported in January 2020 in the southernmost state of Kerala. And Kerala has one of the best public health infrastructures in the country, and immediately immediately took steps to isolate the infected person. Contact tracing was carried out, and healthcare workers were also isolated. This was before any kind of national policies or guidelines were actually introduced in India. And incidentally, on the same day, that is the 30th of January, the WHO announced SARS-CoV-2 as a public health emergency of international concern. Following this, in March, Prime Minister Modi announced a 21-day lockdown when India had over 500 confirmed COVID-19 cases. Now, this was enabled through two different legislations, the Epidemic Diseases Act, which, as you can see, is a colonial era legislation, and the National Disaster Management Act of 2005. These two legislations essentially authorize the government to restrict human mobility and activities to essential services. So how exactly can you actually ensure that 1.4 billion people actually adhere to COVID-appropriate behaviors? So in this particular analysis, I used securitization theory and framing theory to analyze speeches made by the Prime Minister. So the Prime Minister is, of course, a legitimate political authority who holds considerable power to actually enact a security, to enact these particular measures. So the way this was done was that he framed COVID-19 as a security threat by utilizing linguistic reservoirs that resonated with the audience. So in some of his speeches, he referred to SARS-CoV-2 as an invisible enemy that needed to be combated. He referred to the need to go on a war-like footing to address this particular enemy. And he referred to certain cultural references. So he refers to the Mahabharata, which is a reference to an ancient epic. And this is refers to a particular war, which was actually won in 18 days. So when he invoked the 21-day lockdown, he compared it to the 18-day war, which was won before, to say that we can overcome COVID in 21 days. And this immediately resonated with the public. And he also referred to what's known as the Lakshman Rekha, which is another cultural reference, which refers to a boundary or a rule that should not be broken. And this was so that the public would understand what social distancing meant and what a lockdown meant as well. And some other speeches also go on to talk about how we have to be how we have to work in solidarity, how we need to show compassion towards healthcare workers, and how we need to make sacrifices or temporary sacrifices so that we can actually win this particular war against the virus. Now, so what this demonstrated was that a credible and a legitimate political authority, that is the Prime Minister, who was at that time two-time elected Prime Minister, was able to frame a novel virus as a threat by using these particular cultural references, fully well knowing that these phrases would resonate with the public or the audience of these speech acts. Now, what securitization scholars have also found that it's not always necessary, it's not always enough for a single securitizing actor to actually ensure that exceptional measures are adhered to. So in this particular analysis, I looked at the media as well. So the media were found to actually convey the same securitizing claim that the Prime Minister had made, thereby legitimizing the need for these particular exceptional measures. And we've established that the media are, of course, essential in communicating health emergencies. And during this time, I think it further conveyed the need for COVID-appropriate behaviors. So it also gives, in my analysis, I also found that there was an alternative frame that the media had actually conveyed. And this brings us to the question of what are the implications of securitizing a health issue and what are the implications of not doing it. So this gives rise to the alternative frame that the media had actually conveyed. So I found that in their capacity as the fourth estate, they actually highlighted the plight of migrant workers in India. So migrant workers in India referred to any person that migrates from one region to another. So it could be from an urban region to another urban region or a rural region to an urban region when they're in search of work. And so when the lockdown was actually imposed in India, there was only a 4-hour notice that was given to the public. This meant that these people had to actually return to their homes, and they had to make this journey either through bus or on foot. And so these are just some of the photos from the media that I was able to pick up. And there was a mass migration of about 11.4 million people, which comprise 90% of India's informal sector. And there are about 1,000 non-COVID related deaths. So this is just an example of how the announcement of the lockdown actually impacted the public, and it wasn't in a sector that had anything to do with health at all. And that was just reflective of the silence and the speed with which the decision-making was carried out. And the reason why I mentioned the silence and speed is not just because of the sudden or the abrupt announcement that was made, but it's also because the decision was actually made without any consultation with the state governments. And that's here when I just want to highlight that India has a federal polity. I'll come back to that point later. But what I wanted to emphasize here is that securitizing COVID-19 also meant that there's a lot of uncertainty that arises, which policymakers cannot actually think ahead about. And it basically reflects their tendency to overestimate their ability to regulate policy action, and also tells us that we need to have certain essential governance frameworks in addressing health threats. So the reason why this is very important is because in India, there is the threat of new and re-emerging infectious diseases is incredibly high. So I've just picked up a few newspaper headlines from the last 1 year in which we've had cases of HMPV, and we've had about 8 or 9 outbreaks, Nipah virus outbreaks since 2018. And every time that there is any kind of outbreak, there is a tendency for these issues to be securitized, and people are generally just trying to predict when the next lockdown will happen. So these are headlines from January 2025, as well as 2024 and 2023. So there's this tendency now in the discourse that the securitization of all infectious diseases or everything could actually, securitization of everything is actually happening. And so this illustrates how that COVID-19 securitization is shaping India's current responses. And there is this urgency for us to move away from these particular responses and instead adopt sustained health preparedness strategies. And so that comes to my current work right now at a think tank, the Observer Research Foundation, in which we're trying to look at the action point of view. So we did convene a roundtable conference to engage with policymakers and experts on this particular topic, that is to strengthen India's health security framework by enabling this kind of dialogue and facilitate and to include participants from not just the health sector, but also biotechnology, security, social sciences, government, and policy domains. And these proceedings are actually synthesized, and expert perspectives and policy recommendations were actually formed, and we've published a report strengthening India's health preparedness. So this was just a different approach that I had actually taken out in order to further analyze India's health governance framework. So the 4 main areas that we looked at were governance, surveillance, medical countermeasures, as well as healthcare demands. So in these particular findings, what we found is that when we're looking at the management of health threats in India, we have to remember that we have a federal polity. And so in the case of COVID-19, as I mentioned, it was a heavily centralized decision-making process where most of the decision-making vested with the central government. And as I said, there was hardly any consultation with the state governments. And because of the speed with which, or the abrupt nature with which the decision-making was carried out, it meant that the states were not exactly prepared, and the public was also not prepared either. And the other issue that comes with this is that in India's federal polity, state or the constitutional powers and responsibilities of health actually vests with the state governments. And this is actually something that's advantageous because of its geographic distribution. Each state in India has its own unique needs, capabilities, and capacities. So that's quite advantageous. But when you're dealing with a health threat of pandemic or epidemic potential, or even a deliberate deliberate biological attack, you need to have coordination within the entire country. So the Epidemic Diseases Act, as I mentioned, is a colonial era legislation, and it's very outdated. The National Disaster Management Act is not actually suited for a public health emergency or an accidental or deliberate biological threat. It's actually more suited for a natural disaster. And so both of these legislations, they fail to address allocation of powers, data sharing, and healthcare demands. And this just highlights the need to improve governance and legal aspects of managing biological threats in the Indian context. So I just want to briefly touch upon surveillance aspect. So surveillance was carried out quite well across the country, but it was highly centralized, which meant that there was a lack of integration at the state and the local levels, and it meant that there were certain areas, such as rural areas or marginalized communities, that were excluded from these particular analyses, which meant that genomic surveillance data was lacking from these particular regions or communities, and there wasn't enough integration with the private sector, when especially 60% of the public go to the private sector for their healthcare needs. And of course, when we're talking about re-emerging and emerging infectious diseases, the One Health approach was not quite comprehensive enough. And so India has since then set up a national One Health mission in order to ensure that there are activities between the different sectors, but this is still not integrated enough. Another issue that came into being was data privacy and protection. So India developed its own contact tracing app during the peak of the pandemic, which is known as the Arogya Setu app, but this lacks any kind of data protection or privacy, and this is also another issue that the country is facing right now in terms of tech development. In terms of medical countermeasures, there were certain supply chain bottlenecks, especially in having access to N95 masks, PPE kits, viral transport medium as well. And this also meant that self-reliance was a big issue. And connections with startup companies and larger companies in financing medical countermeasures were delayed due to regulatory approvals. And India also lacks a robust clinical trial network as well, which further delays the production of these particular viral countermeasures. And of course, with having during a surge, we also know that access to primary healthcare facilities was also limited. So in this particular report, we were able to formulate certain recommendations, which the main one being the need for a Public Health Emergency Management Act for India. So it needs to have a centralized coordinated strategy, which enables proper coordination with the state governments as well. And there's also a lack of a national biosecurity and biosafety network as well. And the other one that I just wanted to briefly mention was about the need for integrated data infrastructure to ensure that early warning systems are put in place during these kinds of threats. And dedicated public-private partnership framework to address health crises, so that there's preparation not just during the crisis, but also during the peacetime as such. And operationalizing One Health with top-down and bottom-up approaches, because as we've seen with a lot of the Nipah virus outbreaks, there needs to be a lot of coordination with social scientists as well as community care workers to understand how this how the viral spillover works. So the final slide is where to next. So since India's undergone this transformation from visualizing health as a development agenda into a security agenda, it's extremely vital to facilitate these kinds of discussions on governance and legal aspects on how India manages biological threats. And I think that this is quite an opportune moment with the IHR amendments and the pandemic agreement, as well as the ongoing PABS negotiations. This is an ideal moment for India to mold its health governance framework, and of course, being a global health actor, being one of the key production centers of vaccines and diagnostics, I think it's essential that India be able to do this. Thank you.